Hello and welcome. Thank you for joining me. My name is Josiah Obiero. I am a fourth-year pharmacy student at the University of Saskatchewan. Today I'm going to present on the new agents of diabetes mellitus. The objectives of this presentation is going to be to introduce the new agents or diabetes agents in the market and their place in therapy, to give a brief evaluation of the evidence for the new agents, to discuss the costs and a drug plan coverage of these new agents, and to discuss some clinical pearls of diabetes pharmacotherapy. There are two types of diabetes, type 1 and type 2. Type 1 diabetes patients don't produce any insulin. Type 2 patients produce insufficient amount of insulin, or they produce sufficient amount, but their tissues are insensitive to the insulin that is available in the body. Both these two types of diabetes lead to hyperglycemia. Hyperglycemia, in turn, contributes to cell damage in a variety of tissues, in the eyes, in the nerves, and in the kidneys. It's also a risk factor in cardiovascular disease. So it is important to control the blood sugars. Currently there is no cure for diabetes. So the cornerstone of therapy is controlling hyperglycemia. For type 1 diabetes, the treatment is insulin. For type 2 diabetes, there is various treatments, including insulin. And the focus of this presentation is going to be type 2 diabetes. The first line treatment for type 2 diabetes is metformin. Usually you start at a low dose and you titrate to the desired dose because of the GI side effects, which can be tolerated if you start slow. Over time, it will be well tolerated. The maximum dose for metformin is 2.55 grams in divided doses per day. The reason it's first line is because it has good efficacy. It lowers A1C by about 1 to 1.5%. It has proven benefits in mortality reduction and also reduction of cardiovascular events in patients who get on, in the type 2 diabetes patients who start metformin. It also has a low hypoglycemia risk as monotherapy, and it's weight neutral, and this can be beneficial to some patients who have type 2 diabetes. If the type 2 diabetes has not been controlled by metformin, there is a number of second-line agents that can be used. DDP4 inhibitors, GLP-1 agonists, SGL2 inhibitors, insulin secretagogues, thiazolidinediones, and insulin. And the choice of these second-line agents is based on patient factors, including whichever comorbidities they have, and the side effect profile of the medications, and patient preferences. This is the list of the recent antihyperglycemic agents in the market. The first one is a long-acting insulin called Tresiba, or generic name is Degludec, which came in the market in 2017. The next class of recent diabetes medications is SGLT2 inhibitors, which came in the market around 2014, 2015. And the ones that have been approved in Canada include Forxiga, Invokana, and Jardiance. And the names in brackets are their generic names. The next class of new insulin agents in the market are GLP-1 agonists. First one approved in it was Victoza in 2010, but there's been more recent approvals from 2015 to 2020, and that includes Saxenda, which is a higher concentration of Victoza, semaglutide, which is Ozempic or Rybelsus in 2020, Adelixin in 2017, Trulicity in 2015, and Bydureon in 2015 as well. The next agents I'll talk about is insulin combination agents with GLP-1 agonists, and that's going to be Soliqua in 2018 and Zaltopi also in 2018. Also, we'll talk about SGL2 inhibitors in combination with metformin, and that is Xigduo in 2016, Sinjadi in 2016, and Invocamet in 2016 as well. As I mentioned, Tresiba came in the market in 2017. It is similar to human insulin, except there's 2 changes in the amino acid level. And those changes have profound effects on the pharmacokinetics of insulin. It exists as a small molecule in solution, but when it's injected into subcutaneous tissue, it becomes a big molecule, and that has profound pharmacokinetics changes. It basically increases its half-life considerably. And as you can see, the duration of action can be up to 42 hours. And that is the longest duration of action of all the basal insulins in the market today. And it has no peak, and that contributes to its lower hypoglycemic risk. In comparison to other basal insulins, the price is comparable. It's within the range of the other insulins. It's open benefit in Saskatchewan drug plan, and also it's open benefit in NIHB drug plan. The long duration of action, it might be quite beneficial to patients who have poor adherence or shift workers who may not have regular schedules. There is high concentration available of degludec, and this is important for patients who require higher doses. That means they can inject smaller volumes, and that improves injection technique and is more convenient for the patient. And because it has a very long half-life, it's suggested that you titrate slowly once weekly, as opposed to every few days for the other types of insulin. The next class of medications I'll talk about are GLP-1 agonists. GLP-1 stands for glucagon-like peptide. It's an incretin hormone that stimulates glucose-dependent release of insulin. It also slows gastric emptying and suppresses inappropriate glucagon elevation. GLP-1 agonists are similar to the natural GLP-1, except there are a few modifications at the amino acid level, which enhances their stability. They are fairly efficacious agents. They reduce the A1C by 1 to 1.5%, which is comparable to the top agents, metformin and sulfonylureas. They lower they also are shown to be beneficial in that they lower the risk of major adverse cardiovascular events, with some of the GLP-1 agonists, and that includes Victoza, Ozempic, and Trulicity. Another benefit of these agents is weight loss. That is, patients experience a 3 to 4 kilogram weight loss, and this might benefit patients who have higher BMIs and type 2 diabetes. The major adverse events of the GLP-1 agonists is GI upset. There is nausea, vomiting, and diarrhea. But like in metformin, if you start slow and go slow, this can be overcome over time. There's also a suggestion that giving smaller meals with less fat can also lessen this GI upset. The hypoglycemia risk is quite low. It's in the clinical trials, they were basically placebo and GLP-1 agonists were basically the same. But when it's used in combinations, like with insulin, it can intensify the risk of hypoglycemia. The rare but serious side effects include gallbladder disease, which you can see in Victoza is 3.9% as opposed to placebo 1.9%, but this is also been shown to be a class effect. There is a black box warning about thyroid cancer, but this is not based on clinical trials. This is based on animal studies where study animals had increased incidence of thyroid cancers, but it's not been shown on clinical trials. So the guidance from FDA states that if a patient has a personal history or a family history of thyroid cancers, they should not be given GLP-1 agonists. The cost and coverage, Adilixin is not listed in the Saskatchewan drug formulary, but it's open benefits in NIHB, and they're quite pricey, almost $800 for 90 days supply. Again, like other agents, the recommendation is to start slowly and titrate up to a maximum dose of 20 micrograms sub-Q daily after meals. Ozempic, it's EDS in Saskatchewan drug plan, and the EDS criteria is that it can be added to metformin and sulfonylurea in patients who are using both and try diet and exercise, and they're still not reaching their glycemic targets. It's similar criteria in NIHB on patients, but patients only need to have tried metformin, diet and exercise, and are not achieving their glycemic targets. And Ozempic is titrated slowly to a maximum dose of 1 milligram subcut weekly. The other GLP-1 agonists are not listed. GLP-1 can be combined with insulin. They are both injectable, and they can be particularly beneficial for patients who have trouble controlling their postprandial peaks. So if you have a patient whose fasting glucose is within the normal range, but they're not reaching their A1C targets, that would be a good patient to have a combination of insulin with GLP-1 agonists. And they're also a good combination because they might help mitigate the weight gain that is caused by insulin. So the first combination agent is Soliqua. It's not listed on Saskatchewan drug plan, but it's open benefit in NIHB. And as I mentioned before, GLP-1 agonists, they're contraindicated with patients with a history of thyroid carcinoma and also pregnancy. The other combination agent is Zaltopi, but it's not listed in any of the formularies. So in summary, there is no difference in the A1C reductions among insulins. The choice is based on side effect profile, hypoglycemia, possibly the cancer risk with glargine, cost and convenience, and other patient factors. Insulin is preferred in pregnancy, in poor kidney function, or uncontrolled diabetes with oral agents. The next class of medications I'm going to talk about are SGLT2 inhibitors. And SGLT2 inhibitor stands for sodium glucose cotransporter 2 inhibitors. And these inhibitors work by inhibiting glucose reabsorption at the proximal convoluted tubule of the kidney. Since glucose reabsorption is decreased, there is an increase of glucose excretion, and that's how they lower the blood sugar. There is 3 approved in Canada, Jardiance in 2015, Invokana 2014, and Forxiga in 2015. The efficacy, they're not quite as efficacious as the first-line agents, as the first-line agent metformin. They reduce A1C by about 0.5 to 1%, as opposed to 1 to 1.5% for metformin. And they're all equally efficacious in terms of A1C reductions. They also can be beneficial, like GLP-1 agonists, because they also can lead to weight loss. They also are act as diuretics, and they can reduce blood pressure as well. The main benefits are in the comorbidities. The first one I'll talk about is renal benefits. There is evidence that shows that SGLT2 inhibitors have nephropathy benefits. The best evidence is with canagliflozin and in a trial Credence, but others have also been shown to be beneficial in renal protection. Overall, they reduce the risk of progression of renal disease by about 45%, which is quite considerable. However, you need to be careful when you start using SGLT2 inhibitors, especially in patients who have low kidney function, which is almost counterintuitive. But it's because initially when you start using them, they've been shown to increase serum creatinine and lower kidney function. And especially if the kidney function is already lowered, it's feared that they might trigger acute kidney injury. But once you go past that initial phase of starting and the numbers normalize back, then they've been shown in the long term to be beneficial to chronic kidney disease. So the recommendation is once you start these agents, you monitor kidney function closely until it stabilizes to baseline. Another thing to keep in mind is that the A1C reduction might not be as good for patients who have low kidney function, because the sugar reduction mechanism depends on a good kidney function. That's how the SGLT2 reduce their sugars. The next benefit of this SGLT2 inhibitors is cardiovascular benefit. Evidence shows that SGLT2 inhibitors have heart failure benefits of patients with reduced ejection fraction. Basically, they reduce the cardiovascular death or hospitalization for heart failure by 23% on average in patients with a history of heart failure. The mechanism for this is not clear. It could be related to the renal protection. So if they slow CKD, they might also slow heart failure. Or it could be related to the diuresis benefit, the diuresis benefits, so which also will reduce fluid volume and perhaps reduce hospitalization for heart failure. They have a low risk of hypoglycemia, basically similar to placebo, but this effect intensifies when they're combined with other agents. The main side effects are yeast infections. They increase yeast infections in both men and women. And they also increase urinary tract infections in, in both, again, men and women. There are some rare but serious side effects. Diabetic ketoacidosis, basically, there was a slight increase to 2.2 versus 0.02 events per 1,000 patient years. There was an observation in one of the trials, Canvas and Canvas R, about an increase in foot and leg amputations on patients with using canagliflozin, 5.9 versus 2.8 placebo. But this has not been shown again in any of the other SGLT2 inhibitors. So it may or may not be the case that they increase SGLT2 increase the risk of leg and foot amputations. The drug coverage and cost, they all about the same. They cost about the same amount. Forxiga is EDS in Saskatchewan drug plan, and is for patients who have failed metformin and sulfonylureas, and also cannot use insulin for some reason. And for NIHB is the same for patients who failed metformin or sulfonylureas. For Jardians, the criteria is the same for EDS, except that they also have to have had a history of heart failure. And for NIHB, it's the same as Forxiga. And for canagliflozin, the EDS criteria, it is the same as for Forxiga. And also NIHB is also the same for all the three agents. So must have failed metformin and sulfonylureas. For the combination products, we have Xigduo, which is dapagliflozin and metformin. And for NIHB, again, the criteria is the same as the criteria is the same as for getting dapagliflozin. You must have failed metformin and sulfonylurea. And for Saskatchewan drug plan, it is the same as NIHB, except that you must have tried dapagliflozin by itself first and shown some benefit before you qualify for the combination product. For Synjardy, which is empagliflozin and metformin, it's for patients eligible to receive metformin and empagliflozin to replace individual components. There is some other combinations in the market which are not on formularies. Q10, like Zampi and Invocamet, but they're not listed on any formularies. So in summary, take SGLT2 inhibitors in the morning. They tend to increase urine output. Monitor blood work when you start SGLT2 inhibitors, 2 to 4 weeks, every 2 to 4 weeks until they stabilize back to the blood pressure, renal function, and electrolytes have stabilized. And the main place in therapy is for patients with comorbidities, such as heart failure and chronic kidney disease. And there is recommendation to all SGLT2 inhibitors during acute illness because they can cause hypovolemia. They have some diuresis action, and that can also throw off electrolytes during acute illness. Thank you very much. That's my email. I would welcome any questions. I'll do my best to, if you send me an email, to respond to any questions that you might have. Thank you.